The assessment of the lower leg looks at injuries to the tibia, fibula, ankle joint and foot soft tissues. Subjective questioning would have given the therapist an indication of the patient's problem and would have been completed prior to the physical assessment, as follows. The therapist observes the asymmetry of the patient in walking and standing if able. Acute injuries would be assessed on the couch. The therapist assesses the patient by asking them to walk up and down, checking for any abnormal gait or obvious lack of asymmetry. Walking on the spot and looking straight ahead when asked to stop sets the patient in a neutral balanced position for observation of their standing posture. Observation from the front will show any bruising, swelling or scarring to the lower leg, ankle and foot. The position of the feet being straight or angled outwards, the arches being high or flat, and for any signs of pronation or supination. Observation from behind involves looking at the calf musculature for bruising, swelling, lack of bulk due to wastage, the Achilles tendon for thickening, scarring, and shape. Bowing out gives a varus or supination tendency, or bowing in gives a valgus or pronation problem. The therapist will now check the patient's range of movement by taking them through active, passive and resisted movements. Having completed the walking and standing assessment, the patient is now assessed on the couch in long sitting. A visual check of the limbs is completed for bruising, swelling, etc. The patient is then initially taken through active movements of dorsiflexion, plantarflexion, inversion and eversion, looking for stiffness, pain or discomfort, comparing one ankle with the other. Passive movements taken through the same ranges are repeated on the injured limb, again looking for lack of mobility, flexibility, pain and discomfort. Structures are being stretched or compressed during these passive movements. Resisted movements can be done isometrically, as demonstrated, or if there is less of an acute problem and the strength of the movement needs assessing, they can be resisted isotonically. Here, the muscles and the tendons are being assessed for strains or inflammatory pain, which will always be present on resisted activity. During the range of movement assessment, the therapist will note any pain or restrictions. Palpation of the bony and soft tissue structures will show any areas of tenderness or pain in connection with the injured structures. The initial palpation is done with the knee bent, feeling the bony palpable structures of the tibia and fibula. And then the soft tissue structures are palpated, examining the anterior compartment, which includes tibialis anterior, and the long extensors. The lateral compartment and the perineal muscles, and finally the posterior compartments with their deep and superficial musculature, the deep flexors, tibialis posterior, gastrocnemius and soleus muscles. With the legs straightened, the bony structures of the foot can be palpated, starting with the medial and lateral malleoli and the prominent bony points of the sustenaculum tali, navicular tuberosity, cuneiforms, perineal tubercle, and the head of the fifth metatarsal. The remaining tarsals, metatarsals and joints of the toes are also palpated. This is followed by the soft tissue structures of the anterior tendons, the medial deltoid ligament with its anterior, intermediate and posterior fibres, and finally the most commonly injured structure of the body, the lateral talofibular ligament and the calcaneofibular ligament. Turning the patient onto their front, ensuring the foot is over the end of the couch, allows a more detailed assessment of the calf musculature. And Achilles tendon. Active movements of the foot whilst gently gripping the Achilles tendon may sometimes demonstrate crepitus, a noisy grating if tendinitis is present. With the knee bent, the structures on the sole of the foot can be easily palpated: the calcaneus, plantar fascia, and the longitudinal and transverse arches of the foot. Soleus can also be stressed with the knee bent, as this relaxes the biaxial muscles of gastrocnemius.